techniques and field changes. And least to say, we forget the angle. So actually it is not a trilogy. And this is the first message, that there are 4 things you have to see in glaucoma and 4 points on which you can have a suspect, and not only 3. So you can have a suspect based on the appearance of the optic disc, based on the raised pressure which you have recorded, or suspicious field changes, or narrow angles and angle changes. Based on all these things, you can have a suspect. Because it is a progressively blinding condition which can best be controlled but not cured, and earlier intervention tends to give a better result, especially younger the patient, the earlier intervention is highly recommended. Because of this, when we see patients, we always keep on evaluating and seeing, and we see patients like these, and we are always having a high degree of suspicion. Something has gone wrong. So we have a high degree of suspicion, and we keep on trying to find out. This is the long, sorry, I have made a mistake and the presentation has wrongly opened. The half done presentation has opened. So give me a minute, I will get the right presentation in. This is the wrong presentation.
There are 71 slides.
So yeah, no, that 70, I had a presentation, but there is some mistake has happened. Anyway, I'll have to bear it because something has got added where I did not put. Anyway, so coming first to the optic disc, and the optic disc is very often the first place we look for. And we know the evaluation of the optic disc that we commonly have been taught, which is looking at the 5 R's. So we look at the disc rim to evaluate the disc size. Then we look at the neuroretinal rim. And then we go on here. I can show with this, yes. So this is the disc rim that we evaluate the size. And we know that there are confounding factors based on small disc as well as large discs. Then we go on to look at the neural rim. And we have been taught very well that the neural rim is thickest coming inferiorly. And then it becomes superiorly. Then it becomes temporally. And temporally, and then it becomes smallest nasally. So that is the isn't rule. The temporal rim is the thinnest, and that is the way it has been taught to us. After we have looked at the neural rim, then we are going to start looking at the peripapillary area to see whether there are any disc hemorrhages or whether there are any peripapillary changes, and that is the way we are going to look at the optic disc. And very often we find patients like in this, there is a vertical elongation of the optic disc with the inferior rim a little thinner, but there are no notches anywhere. There are no peripapillary changes. There are no disc hemorrhages. In this manner, we are taught to keep on looking at the disc. I'm not going to the next slide. And these are some other discs, and you can see over here, classical nerve fiber layer defect is seen along with notching here, and the notching is well delineated because you can see the deviation of the blood vessels over there. And there are no other hemorrhages or other peripapillary changes. And here you can see a patient whose thinnest rim is superior with a full notch going right up to the scleral rim. Similarly, here there is a total loss almost of 1/4 of the disc with a big area of neuroretinal rim loss. So these are all the changes we commonly look for. And there have been a big list of changes which are described. But the most important point which I would like to make in this talk is, what is the weightage do you get to these, what do you give to these findings? The first is the notch which goes up to the rim. Any notch, a small notch which is seen as I shown in the first photograph, it is just a little thinning, but it is not going up to the edge of the rim. And with a nerve fiber layer defect. Such a defect is very specific for glaucoma, and it has to be kept in mind and should put the patient straight away in the disc suspect category. If there is a thinnest point anywhere which is other than the temporal edge, may not be going right up to the rim, but if the thinnest point is not the temporal edge, then also it is a very important point. If there is a disc hemorrhage at the margin of the disc, especially with accompanied with a notch and a nerve fiber layer defect, then it is very specific, and an acquired pit. These are the changes which if you see on a disc, you are going to give maximum weightage. Other findings which I am pointing out here can be what I call note value. You definitely have to look for them. Very commonly, patients have been referred to me saying that the inferior rim is thinner than the superior rim. The inferior rim being thinner than the superior rim is a flag sign, but is not so specific a change. And a lot of patients with this kind of finding may very well be normal. A large cup, because in olden days we had been taught to look at the cup disc ratio. Any cup disc ratio which was more than 0.6, we started suspecting glaucoma. But now we have been told very well that large discs have large cups. So you can look at a disc with large cup, note the finding and keep on watching for it, but you may not straight away classify or suspect just on having a large cup. Same is true with the vertical elongated cup, especially if it is all even neural rim and no notable notch is seen. Other vascular signs such as bearing of the blood vessel, bayoneting of the blood vessel without any notch or nerve fiber layer defect, just a little bearing in one position, it is a sign which you may keep in record, photograph and keep on watching over time, but you cannot just put a patient as a disc suspect based only on that. Tilted and irregularly shaped discs, there is no definite guide on how much importance to give to all these signs, because all the rules of isn't rule and those rules which we apply do not apply to tilted irregular discs, as well as patients with very large peripapillary areas. You cannot apply these rules and you may have to put them as suspects. Coming to the visual field and how we find suspects on visual field, we know very well the classification of these various zones and how to interpret the single field printout. Numerous times we have been taught, and then we look at the significance levels of the defects and the Anderson's criteria. But most important part of the Anderson's criteria is the location of the field, which many times we don't take into consideration. These are the typical locations where the field changes occur in glaucoma. Definitely the first 4 are the ones in the early stages. The second 4 are more advanced stages. So when we are looking for very early glaucomas, if we find 3 points, as it describes 3 points, but if the 3 points are lying 1 on this side and 2 on this side of the horizontal meridian, they do not satisfy the location criteria which is there in the Anderson's criteria. They will say 3 or more contiguous non-edge points in typical area. It is a typical area which is known to be affected by glaucoma. So just any area, 3 points are not as significant as the location that you see the points. Also, you have to keep in mind that visual field is known to have performance errors, especially the first field. And it's said up to 3 fields you may have to take to get really reliable fields. It is also prone to have what we call short-term and long-term fluctuations, and it is definitely affected by media opacity. So these are some very common examples of artifacts and errors which occur on perimetry. This low reliability produces what we call a typical clover leaf defect, and you have to keep in mind for these kind of defects. And this is an example where you see the optic nerve and it shows very, very regular neural rim. It is a little small nerve, but it does not show any sign which is raising the alarm for glaucoma. But if you do the visual field, you find something over here. So when you find something which does not match, even though it is a reliably done field and it is not remarked as being grossly unreliable, but still we are getting a patch which is there on both the total as well as pattern deviation. And you would like to confirm whether this is real or this is an artifact. So you have to repeat the test, more reliably done test, and there you see the same defects have disappeared. This is a typical white scotomas that we call in a patient who is trigger happy. So false positive errors. And this is a typical lens rim artifact. So you have to know how these artifacts look. The important point is that the artifacts are better seen on the gray scales rather than seeing on the pattern deviation, which we are going to look at when we see or glaucoma defects. The point I would like to show is that reliability indices are still good, though this is an artifactous field. So reliability is one issue, but producing artifacts can even occur in reliably done fields. And also this is another example, reliability factors are good, but you see the field and see the effect is totally patchy. The optic disc to match with looks very, very healthy and very unlikely to produce any defect. Seeing this disc, I wouldn't anticipate any defect. So we repeat the field and you see that these are all artifacts. So there's nothing which you can explain that why this has happened, but still you get fields which are very bizarre and you need to repeat them to be really sure what it is. So you have to do a reconfirmation for the visual field before you start labeling a patient as optic disc suspect or a visual field suspect. So you have to correlate with the optic disc and fundus findings, account for performance errors and learning curves, and look for specific artifacts before you label a defect you see on the visual field as a probable glaucomatous defect. So here you have an example of an optic disc and a matching visual field, and as you can see very well that here in this region you can see the deflection of the nerve. The color is not so good, but there is a little notch developing here, and that can explain this inferior visual field defect that you have. Only thing is that you get something over here which doesn't seem to be explained because the inferior nerve rim all through looks very, very healthy. So what is the thing which is producing that? And that is the most important thing. You need to do a full fundus examination, and you can see that there is a scar over here which somehow is producing that defect on the visual field. So you have to look at the fundus also before you make your final conclusion. As a continuity of the disc examination using OCT, which is the most commonly used test today, and it is very, very useful, but the caveat is that it is used judiciously. Most misused test, and Dr. Nayak's favorite word is that most misused and abused test in glaucoma evaluation today is OCT, because it is sometimes being used as an alternative to a detailed clinical exam. Many times it is used as an alternative to visual fields because both the doctor as well as the patient don't like visual fields, but you cannot determine amount of damage on OCT, which is very necessary to decide your treatment strategy. So you have to have a visual field to correlate with your OCT. Having said that, as I said, OCT is very useful in getting evaluation, whether the defect you see on your clinical examination, you come to know the depth of the defect and you can document it and use it for follow-up. So it is definitely a useful test, and we know very well the layouts where, so I'm not going into details, but one important thing I want to point out is looking at the segmentation down here, because if you segmentation is equivalent to the gray scales in your visual field, and if there are any artifacts or any imaging defects where the machine is making a mistake, it will show up on your segmentation graphs over here. So if you see the segmentation not being done properly, or if you see shadows inside, that means that your data is likely to be affected by it. As I said, it is effectively used to reconfirm and document the changes you see on the optic disc clinically. Then you correlate it with your visual field, and then when you use it to evaluate progression along with the visual field, it is one of the most robust ways of knowing whether your patient is really getting worse or not. But in some cases, certain cases, it is quite useless. And in areas with large peripapillary atrophy, tilted discs, very high myopes where you don't get reliable images, this test is quite useless and it may not be worth doing at all. So looking at some examples, as here you can see this optic disc, it does have a little bit of peripapillary atrophy in both sides, but still we have been able to get a reliably good image, and it reconfirms our finding where there is a superior notch here. And incidentally, this is the same patient I showed who had a defect in the superior field produced by the defect in the chorioretinal scar. This is another example where if you examine carefully, and this is sometimes missed on color photographs, that there is definitely a notch over here, which is somehow not seen very well on the color photograph. But when you do a 3D examination using a dilated pupil and a 90D lens, you are going to be able to see it. The nerve fiber layer defect is noticeable, but in this small picture, it is not. But it is picked up very well in the OCT. So this is another example where the deep notch seen inferiorly in matching nerve fiber layer defect is very well picked up and delineated in the OCT. And the right eye, which looks normal, is reported as normal. So we are just reconfirming what we find, and we can use these very, very nicely for looking for change over time. Having said that, there are sources of error even in the OCT, and here you see a big blink which is producing, and this is what I was telling you. Look at the segmentation picture over here, and you can see the big defect here, and even on the optic disc segmentation, you can see the defect. This shows you clearly that this machine has gone wrong over here, and therefore the data it is going to give you is going to be erroneous. You repeat the test with a little more cooperation from the patient, and you get a much more useful, reliable picture. This is another example where the technician has taken the image, and here it is a total guesswork because you look at the segmentation pictures. Only thing what you see is that in these two pictures you should be seeing the optic disc, which looks like this one, which is there in the earlier picture. You see the optic disc, but in this you don't see the optic disc. It just looks like retina. So you know that this is a wrongly centered scan, and the machine is not able to pick up this wrong centering. If you see all the reliability indices and all over here, they are fairly good. Only you have to use your brains and see that this is a wrongly centered picture. Repeat the centering, repeat the picture, and then only you will get the useful image. If this is the image you had got and you had relied on this, you would have gone completely wrong. This is another example where the image, this is for the GCC complex picture, and the centering is not done correctly. I don't know, the machine is supposed to center itself correctly, but it doesn't do it. You do it properly, repeat it, and the data you get is quietly different. This is another GCC image, and you get something bizarre over here, and that is something which is not seen later on. And what is that? That is because in the macula there is a huge CNVM developed in the period, and we have missed it and done the GCC. That also happens sometimes. So coming back to the optic disc, once you get this fundus picture OCT, you do serial fields, you do the follow-up. As I was telling you, follow-up, it's very important to use the visual fields for follow-up. And as you can see, this is the baseline, and then this is the follow-up image, and you can see the new field defects have developed in the inferior field, as you can see over here. But when you do the fourth field, for some surprising reason, the defects completely go away. So even when you see progression, you have to do more than one field to look for progression again. This is the imaging. That time, when I saw this patient, I used to use the HRT. But this is what shows on the HRT. All through the whole follow-up period, there has been no change. So that is why using both imaging as well as fields simultaneously is very useful in coming to a correct conclusion. So this is another patient who is a disc suspect, and you can see the notch here with the nerve fiber layer defect. So what other tests you will do in such patients? You will have to do a diurnal variation, you'll have to do pachymetry, then go into detailed history of steroid use, cardiovascular shock, because these kind of nerve fiber layer defects can be produced by other events. And as I was saying, don't overlook the angle. This is a patient who in childhood had an injury, and you can see the recession. Though at this stage the pressures are normal, but he has an angle recession. He must have had a period of high IOP post-injury. During that time, that nerve fiber layer may have developed. Needless to say, this patient will have to remain on follow-up. Sometimes when you do an anterior segment examination carefully, you pick up all these signs. So these are not primary glaucomas, but the nerve fiber layer defect has picked it up. Then you look more carefully and you find causes for secondary glaucomas. The most important is today we are all looking at pre-perimetric glaucomas. What are pre-perimetric glaucomas? Glaucomas in which you see discs changes, which may be corroborated with imaging, and absolutely normal white on white fields. So you have this patient who was looked up as a glaucoma suspect because of the asymmetry of the optic disc between the two eyes, and you can see that the right eye, the optic disc is larger, the optic cup is larger in size than the one seen on the left side. And needless to say that I can also say that the right eye, the disc is larger in size too. but the visual fields were completely normal, and this is what the imaging test showed. So this is the kind of nerve fiber layer thinning, and this is not only one test, we did it many times and we still find the same thing. So this is what we call a red disease. For some reason, age match normals show some bizarre pattern of this is not a normal pattern we see of nerve fiber loss in glaucoma. In nerve fiber layer loss in glaucoma, you would see somewhere over here and here. This is exactly the reverse. So this is not fitting into typical glaucoma. And this is what we could classify as red disease. Such a patient you would just keep under follow-up to see what happens. So when you see a periperimetric glaucoma, first you have to consider whether the disc change is consistent with glaucoma. It could be a abnormal disc or a colobomatous disc or some congenital defect. This may be reconfirmed by imaging, and you need to look at the intraocular pressure more carefully, including looking at the diurnals and the corneal thickness. Definitely very important, do the gonioscopy and look for other risk factors like corneal thickness, disc hemorrhage, and pseudo exfoliation. These are risk factors which may indicate that these patients may progress faster than other patients. So you would do a diurnal fluctuation, pachymetry, look, as I said, take the history, and other causes of short IOP spikes, that like what I showed earlier. But the decision to treat, whether it is a disc suspect or it is a pre-perimetric glaucoma category, is on what is the risk of vision loss over the next few years. The aim is to prevent significant vision disability during the patient's lifetime. It is not to prevent the progression of the glaucoma completely. So when the visual fields are normal, and chances of rapid progression to complete vision loss in a short duration are very, very minimal. So optic nerves which have reduced nerve fiber layer thickness in one of the superior or inferior clock hours, nasal and temporal are excluded, below the age match normals are at a little increased risk of developing visual field defects over the next 5 years. And in such patients, it may make a case for early treatment. But you have to keep in mind that nerve fiber layer defects arise out of other pathologies as well and can't take treatment decisions based on that alone. So small nerve fiber layer defects do not cause any vision problem. And as a matter of fact, even are approved for continuing as air pilots. So it does not affect the quality of life of the patient. And therefore, what Dr. Kuldev Singh said in one of the journals is that for the pre-perimetric glaucoma patients, you should not look upon as who are sitting on the edge of a cliff and are going to drop into the abyss of blindness. So rapid progression to vision disability is a very small exception rather than the rule in such patients. So strategies to confirm imaging, if you have seen the defect, is to check for functional damage, look at fellow eyes, and confirm that this is the glaucomatous optic nerve neuropathy is progressive on repeat testing. You can do a repeat testing every 6 months and see whether there is any small progression. And treatment for pre-perimetric category is there if it is definitely in the ACG scenario. But raised pressure needs to be reduced only in presence of other risk factors. And presence of risk factors such as pseudo exfoliation, thin cornea, disc hemorrhages, severe damage in the other eye, or perimetry patient is not at all reliable and therefore you cannot judge the extent of damage, then only you would treat the patient. Otherwise, in all other patients, a careful follow-up and intervention only when detected would be a practical option. Other investigations, sometimes when you see changes and no raised pressure, then you can do the color Doppler, carotid Doppler, 24-hour BP monitoring, nocturnal dips in the perfusion, and serum B12 levels additionally if you feel so. But most important point here is that gonioscopy is an absolutely essential investigation in glaucoma. Even if you have a small suspicion of glaucoma also, you have to do a gonioscopy, because very important treatment decisions are missed if you don't do it. And doing anterior segment imaging using your OCT is not a replacement and can lead to serious complications. So you have to keep in mind these points.
Manish,
which are the patients you will suspect to have Von Herring?
Manish,
yeah.
So I'm just going to interrupt you for 10 seconds, just to tell everyone, announce that, if anybody has any questions, they can start typing it on the chat. While Dr. Manish's presentation is going on, if anybody has any questions, they can start typing on the chat. So we will make a mental note of that. Okay. So carry on, Dr. Manish.
So you have to do a von Herix. You can suspect patients after you see the von Herix and do a gonioscopy with manipulation when you have a suspicion of glaucoma or you are evaluating a patient for glaucoma. This is typical finding you see on gonioscopy is you can see the pigmented trabecular meshwork here, but this is not a typical really open angle, because when you do a little indentation, that time you see the iris moving further down. This is typically what we call pseudo open angle, commonly seen in the inferior angle because of little pigment deposition anterior to the Schwalbe's line. So you can see here, this is the Schwalbe's line. This was the pigment that you saw in the first, and when you did the indentation, the full angle became visible. So the similar thing is there when you look at an angle, it looks closed because you are looking absolute. This is a little bit bulged iris, but it is not a closed angle, because if you tilt the mirror, like if you're looking at the superior mirror, in the superior mirror, you tilt the mirror a little down, or if you're looking at the inferior mirror, tilt the lens a little up. So you look over the hill and you can see that the angle is completely actually open. So you sometimes mistake this for narrow angles. And I have got a video to show you how it is going when it looks going over the hill. As you can see here, when I'm looking, first part is you are looking at the level of the iris, and now you are started tilting the mirror, and you can see here that as you tilt the wing, the trabecular meshwork starts becoming visible. This is typical when you look over the hill. And this is another video of the compression. You can see here, I'm sorry, it may not be very clear, but this is some amount of pigment is seen over here. And you would feel that this is an open angle until you take the manipulation, press it and see the amount of angle that opens. You can see the whole angle opened up. That little pigment there was just a misguide you into thinking that this is an open angle. This is actually a closed angle and it is opening on indentation. So how do you classify the angles after you do the gonioscopy is your first is an open angle, of course, but a narrow angle you call a PCS, or primary angle closure suspect, when you see only apposition. That means when you do indentation, everywhere the iris moves away from the trabecular meshwork in more than 270 degrees, you call it PACS. Sometimes it is less than 180 degrees, in which case you can still call it PACS, but definitely you're not going to do anything. But if you have appositional angle closure with raised intraocular pressure, or you see evidence of synechia, when you do the indentation, in some places you may see the iris continues to remain stuck to the trabecular meshwork because of synechial formation. And when you see this, immediately your classification changes to PAC. This is called primary angle closure. The suspect is removed from here. And the third classification is primary angle closure glaucoma, where a G gets added because you see appositional or synechial angle closure along with disc and field changes. So, and raised pressure. So if you see raised pressure, or you see disc changes, or you see field changes, you are going to classify this patient as glaucoma. And laser iridotomy is absolutely essential in PAC and PACG. PACS, all patients, you may not do a laser iridotomy. You may observe the patient periodically, and you may only treat patients if they are high risk, like if they already have changes in the other eye, or you have a very strong family history, or patient is unable to regularly come for follow-up, or patient is diabetic and needs to have a dilated disc examination. Often then you would probably need to do a iridotomy so that you avoid this complication. But you have to keep in mind, as I said, looking at angles may be the most important thing you do when you have a glaucoma suspect, because the risk of progression to blindness is higher in ACG than POAG. So the example I showed you of a patient who had an inferior nerve fiber layer defect, and we said we can happily observe this patient if nothing else shows up, and it is a pre-perimetric glaucoma, the entire diagnosis and management of this patient will change completely if you find appositional angle closure, because it becomes angle closure patient and you have to do an iridotomy. And even if the pressure is 21, 22, you probably need to put some drops and bring it down. And if you don't do that, the chances that this patient will rapidly progress to blindness is much higher than if it was an open angle. Also today, guidelines based on broad prospective trials is not available in angle closure. and decision is often based on clinical impression of the treating physician. These are limitations, but still looking for angle closure is very important in all patients whom you see. So this was the slide which I want to show you again, is that this is the patient. If you see this kind of finding, you may actually do nothing. If you are find open angles and fields are normal, and you may decide to do nothing. The pachymetry is normal, the other eye is normal. But if you find this finding and see that patient has got appositional angle closure, you would probably definitely do an iridotomy. So now I think we can open for discussion of the question. So how do we go about it? Do we ask people to ask the question, or do I read the questions which have been put here?
Manish sir,
yeah.
So we'll request Barun sir and Dr.
Yeah.
Jain
Yes.
to just in short put their thoughts on this topic within 5 minutes, and then we'll take the question.
Okay.
Barun sir first.
And in the meantime, I think Manish should remove the slide so that we can get chat window complete.
Yes.
Okay. Now I'll try to. Is it gone?
No.
Sir, there is a tab over there. Stop share.
Stop share. Yeah. I got it. Red one. Now is it gone?
Yes.
Yes. So now I can see the entire window for the.
Okay.
Yes.
Okay, Barun sir, your turn.
Sunil, first your comments.
Well, so basically this was a patient. I think what Manish has explained to us is rather how would you evaluate any patient of glaucoma? So apart from he being a glaucoma suspect or no, this is a complete examination which you need to perform for the patient who comes in for a glaucoma evaluation. And that would include not only the intraocular pressure measurement, but the gonioscopy, and then looking at the disc, and ultimately correlating with your field examination. And that's a complete workup for a glaucoma patient. And from that, would you decide whether he's a glaucoma suspect or he's a pure case of glaucoma. And based on that, you would consider your management.
Yeah, thank you, Sunil. So Manish has really nicely covered every aspect. But just 2-3 points I just want to highlight. That one thing we should remember, that the glaucoma suspect, we have to be very careful, because we should not be over treating. Just because one slide he shared in the beginning, where he had said that glaucoma, if we don't start early, probably patient will go blind. So it's a lot of factors you have to see, whether he has family history, high risk, or what's the age of the patient. Because someone who is coming at the age of 65 and just glaucoma suspect and no field defect, and we start treatment, something which I have seen many times, even not only 1, 2, 3 medicines started. So then think of the patient, think of the side effects, and think of quality of life with the medicine that we have started to that patient. So it all, but the same thing, if the patient is 30 years and you have suspicion, then probably you will be more careful, and even the slightest hint, you will think that, okay, I should now start treatment. And the second point I wanted to tell about the polar notch, because in this you have to really, which Manish also highlighted, the polar notch is the main thing which you should, in the beginning, we should look into the disc. And the progression in perimetry or OCT or disc appearance. Progression is again one of the key hallmarks, because the definition of glaucoma is what? Progressive optic neuropathy. If there is some, even if there is some field defect which is not progressing, then you have to think whether I am doing right thing or not. So progression is the hallmark, especially in pre-perimetry glaucoma. But remember, there is one caveat which always I emphasize, that in perimetry or OCT, whatever you are doing, because HRT now it's already gone out of market. So OCT, that you should do it on same machine every time and in the same situation. Also OCT, not that once OCT done at one clinic, second time at some other clinic, third time at third clinic. That machine also should have the centration and registration facility, which the newer machines have. Not all machines, the older machines were not having. So that we could slightly shift the position of recording RNFL thickness measurement, then slight shift, just slight rotation or slight shift to right or left or up and down, all figure will change. So that point also you have to remember that perimetry, and that's why perimetry always I tell patient that in case patient has just come for opinion, cannot come regularly for me coming from far distance, then repeat perimetry over there wherever he was going earlier. Repeat it for 1 year, 2 year. Again, just if you want, you can come back after 2 years with all those findings. But in between, regular follow-up is necessary. And but other and starting treatment, again, I am repeating that one of the studies says that 50% of the glaucoma patients, so it's a study not done in India, outside India, 50% of the glaucoma patients are either being over-treated or don't need any treatment. So just remember, if someone will tell you that you start treatment today and you have to survive for 30 years, 30 years you will be using medicine which is really not required at the first place. So, but because of OCT, closer follow-up, if you take care of those points, because of closer perimetry that you can do, if you can do it regularly and follow it very minutely, then at least you are doing the right justice to the patient and not.
Swapnesh, we can ask some comments from Dr. Rita Damankar also. She is also there.
Yeah, okay.
Yeah, welcome.
Yes, so now probably all important. I'll just read it later on. What are the queries which need to be asked? And yeah, so in the meantime, Rita can give her comment.
I think, good afternoon, madam. I think you already made a very nice observation. Maybe you can tell it.
Good evening, can I come in?
Yeah, please.
Okay. A couple of observations that I made. I think Manish has made a great job of the presentation because he seems to have everything. There are two things that I would actually like to come in and say at this point in time. One is that when you're looking at
I can't hear.
And the audio is not clear.
Yeah.
now, can you hear me?
Yeah,
now we can hear. Yes.
Okay. So I thought of two things that I would like to bring to your notice. One is that when you're looking at the OCT, please also check the signal strength of the OCT.
Yes.
Because if you have a poor signal strength, then you know that you're looking at an unreliable OCT. It's a very simple thing that you can do. Just like you look at the reliability of a perimeter, you can also look at the reliability of your OCT. That is one thing. And secondly, I think when you're looking at glaucoma per se, you have to have the thing in the back of your mind, because the eye will only see what the mind actually believes. If you don't think of glaucoma as an option in every patient that walks into you, you're going to miss out on the suspects. As much as Dr. Nayak says that yes, we see a lot of over-treatment with glaucoma, we also do see a lot of underdiagnosis of glaucoma, and hence that Manish put forth was extremely important. And another point that I wanted also to make just now is that when you said look at the size of the disc. Now, just on looking at the size of the disc, maybe it's not very easy for somebody who's not very experienced to say whether the disc is large or small. You can only probably say asymmetry. But if you look at the size, if you look at the distance between the lateral rim of the disc to the macula, and if you see the size of the macula as compared to the size of the disc, then you can make out whether you have a large disc or you have a small disc. So this is handy in your daily practice. And therefore, because when you have a small disc, there's a lot of crowding of the retinal nerve fiber layers. So even small amount of damage to that little area of the disc might actually entail a lot of loss of retina.
We can now, I think, take the questions.
Yes, we can take some questions. One important question which probably people are thinking how to find out some more cases for cataract. Vishal Kenya has asked criteria to do clear lens extraction in narrow angle glaucoma. Manish, would you like to answer? Or
Yeah. So basically, the criteria for doing a clear lens, and now you have a very specific question. It's not a cataractus lens; it's a clear lens. Yeah. Because sometimes a little cataractus lens, you may get encouraged to remove it, especially if you see on a gonioscopy that angle is becoming more and more narrow, though there are no changes on the optic disc and visual field. But if the patient doesn't have a cataract at all, and especially a patient who is less than 50 years of age, whether we are going to go ahead and remove the cataract or remove the lens only to open the angle up a little more. Now this, the EAGLE study was directed at comparing iridotomies along two lens extractions, and they showed that probably lens extractions can do a better job. And that is, but there are a lot of problems with that EAGLE study and how it was done and how the surgeries were done too. So we can't extrapolate the findings of the EAGLE study directly into our clinical practice today. So removing lenses may be a good idea for many other reasons, but whether it really helps in controlling glaucoma in the long run, the answer to us is not very clear. And I don't think as of now, we are still recommending doing absolutely clear lenses to be removed. However, having said that, sometimes patients who develop angle closure glaucoma, an attack of angle closure, you do an iridotomy and you still find that the lens is, the angle is very narrow, and the lens looks, usually 1 or 2 glaucoma fleckens usually do develop in these patients. So in such patients, if you see the pressures not coming well controlled, just one drug or something, doing a clear lens extraction may be helpful, I still feel, in some patients. But you have to do a very individual finding. Now there are studies which are being done using the anterior segment OCT to find the figures. If you find figures that if lens thickness is more than so much and anterior chamber depth is less than so much, then you can go ahead and do a clear lens extraction. Well, such studies are underway, and soon probably we'll have those kind of figures, and then we'll be doing it more confidently. Go ahead. Sunil and Dr. Nayak can add to what I said.
No, in this I'll add only one thing, that as you rightly said at the end, that if you are pretty sure, not you can't be 100% sure, but pretty sure that these lens morphology, which is really the cause for this narrow angle and sometimes even pressurized and all those things, then definitely yes, I also have done it 3-4 times, but not it cannot be recommended on regular basis, number one. And number two, that remember that EAGLE study, all patients were 50 years plus. So it means that time probably the accommodation is not an important issue that is to be considered. But that cannot be extrapolated. Okay, we'll do the same thing in 30 years also, 40 years also. So whenever you are extrapolating, then one should look into that. Yeah, Sunil, anything?
Apart from that, you need to also look at the disc status and the field status also, especially if patients has very advanced damage. And doing just a lens extraction might add to the rise in pressure spike. So you might just add to the damage. So in those cases, rather continue with your laser PI and your medical medication, try to control the pressures. And probably when the cataract develops, that's when you can take a call, rather than just jumping directly into a clear lens extraction and adding to the pressure spikes.
Okay, thank you. There's one more question here by Dr. Vaishal only. He's asked how sensitive and specific is Ron Herrick's?
So von Herrick's is not at all specific, definitely not. So sensitivity of von Herrick's, there have been studies which have shown that sensitivity is quite good to pick up that the patient probably does have a narrow angle. So it is sensitive, not sensitive enough. So it is only a guide to do gonioscopy. Say you have a busy OPD and you want to know which patient to stick in the gonioscope. You can use the von Herrick as a fast guide, and skip the patients who have von Herrick negative, means whose peripheral corneal thickness, peripheral anterior chamber depths are deep. Then you can say, okay, I will not do a gonioscopy on this patient, especially if everything else is fine. So that is the use of the von Herrick's test. It is not useful to specify that this patient may be having narrow angles.
It's like a screening tool, whether you want to do a gonio or not.
It is to rule out rather than rule in.
Okay, so I think Vaishal has the answer to that.
No,
Dr.
Ravi Thomas had published long back that in combination with torchlight test, means when you throw the pencil torch from the side and see whether what is the narrow angle or not, a narrow chamber or not, and along with that positive von Herrick's, then probably it is more, means it's something which is significant. rather than just one help.
Okay. We have two questions from Dr. Siddesh Bapat. Number one, I'll tell both the questions. Number one, Dr. Siddesh is asking, how do you approach a case of normal tension glaucoma? That is the first question. Second question is, he's asked about the efficacy of some new anti-glaucoma drops like saflutan and ripasudil. And he's asked whether these can be used as primary treatment. So these are two questions.
Yes. So first question is regarding normal tension glaucoma. So first, before you diagnose normal tension glaucoma, you have to rule out the other things. Normal tension glaucoma is a diagnosis of exclusion. So when you first examine the patient, normal tension you have diagnosed because already disc and field changes are there. You say it is normal tension because you didn't find a high tension. So first of all, you have to see the different times of the day whether the patient is actually getting a pressure spike. Needless to say, you have to rule out angle closure glaucoma, because if you see angle closure, then also it is not a normal tension glaucoma. And after you do all these, then you have to look at the fundus and see whether the patient has had, many times patients who have had past attacks of hemi CRVOs, hemi BRVOs present like with a half field defect, and they are labeled as normal tension glaucoma. So you have to examine the retina, and sometimes even after examining the retina, if it is years after the vein occlusion, you don't see any signs of the vein occlusion. So you completely get baffled, but you still have to label them as normal tension glaucomas. So after you see the normal tension glaucoma, the next point is to decide what is the risk factor of losing vision due to this glaucoma. So you see the other eye, you see the family history, you see the corneal thickness, whether the patient has thin cornea, then also he may be misleading it into a normal tension, and it may be actually a high tension glaucoma. And after you have seen all this, then to decide to treat. So some of the normal tension glaucomas we leave untreated. So if the visual field defect you see is not threatening the central vision, and you have a little doubt whether this may be a burnt out glaucoma, like a patient who has had a past history of steroid use and pressure spikes and now it is not there. So in those kind of cases, you may just keep under observation. But if you feel that this is a progressive normal tension glaucoma, then you probably would want to treat it. And in that case, the first option to treat is definitely by medical treatment. Surgical treatment for normal tension glaucoma is a very small segment. And that also, when you have repeated tests and you keep on seeing progression despite all that you can do, and you have to rule out other factors like carotid artery disease and sleep apnea and hypotension before you diagnose it as a progressive normal tension glaucoma. So in short, in 2 minutes, that's how you could best answer. As far as coming to the saflutan and ripasudil.
Manish, before you add, I think the main important point in the IOP measurement, it has to be on a slit lamp based applanation tonometer, yes, and not on any other tonometer, because many times patients are being diagnosed based on IOP reading of some other instruments such as air puff and all. So only if the diagnosis is on an applanation tonometer, and if the pressures are less than 21 millimeters of mercury, would then basically be the diagnosis of a normal tension glaucoma.
Also, just as some patients are in the habit of drinking too much water at one time. In the morning, they get up and first thing they drink is 1 liter of water. And in such patients, sometimes have a tendency to get a pressure spike after that. And that can be responsible for nerve damage. And just stopping that habit can sometimes stop the pressure from spiking and control the glaucoma completely. We have seen such patients. So sometimes when we see defects and cannot explain how they have occurred, asking history about this kind of water intake is also very useful. Along with we always take history of steroids. So along with that, this water also should be taken. Now regarding the second point of saflutan and ripasudil, saflutan is like a prostaglandin. So you have the other three prostaglandins. This is one more prostaglandin. It has been in use in Japan for many, many years, and their effectivity is more or less similar to other prostaglandins. So it does have red eye, it does have the lash growth, and it is to be used once at night. But somehow, in some patients, it is better tolerated when other prostaglandins aren't tolerated. So you can give it a try in the same spectrum. As far as the second drug which you mentioned, ripasudil, which is a new class of drugs, which is called the ROCK inhibitors or the Rho kinase inhibitors. And these are the kind of drugs which are newly introduced in the market. Abroad, there is another one which is introduced. Here they have introduced ripasudil, which was used in Japan before, and we have just started using it. And it is useful, but it is not for primary therapy. So because the saflutan you mentioned, that is a prostaglandin, can be used as primary therapy. Ripasudil generally we keep as a add-on drug. It is not used as a primary drug.
Okay. Thank you, Dr. Manish.
Just one point I want to highlight.
Yeah, yes.
As Manish said, it is not the primary first line of medication, but because it can also take care of partly the inflammation. So in post-operative patients, suppose cataract patient, you have to use this, and I prefer to miss. Now at least I've started using it more often. Maybe whether I'm doing it right or wrong, that time. But in post-operative patients, because you think no prostaglandin I can't give because of the macular edema, the other medicine whether should be give or not. So in that case, I give it in post-operative patients.
Okay. We have 2-3 questions from Dr. Nikhil Gokhale. Dr. Nikhil is asking, do we know the variation between disc parameters on OCT? That is one thing. And then he goes on to ask, is OCT worth doing in tilted discs when you're monitoring the progress of a case of glaucoma? Maybe
in tilted discs, I mentioned in my talk also, I do not find it very useful in very tiny. The typical tiny tilted disc is a typical type of disc where it is absolutely useless. Some of the tilted discs, if they are not very small, then it is probably sometimes helpful. But the important is that you need to get it on a machine which does a proper centering and does a proper carry forward of the exam again and again. And all machines are not equally good in that.
Okay. Dr. Sunil, would you like to?
A point from Manish, what he said, is absolutely means one should remember that even tilted disc may not be first time you have done the test, the finding may not be very useful, because anything which is you cannot examine clinically, probably with the machines also you cannot examine that thoroughly, because all machines are based on the normal, means whatever is the normal disc appearance in that normal disc. So in this, but then what I find, in case if the worst scenario you can't do field properly and all those things, then at least the repetition of the same or the machine where centration and registration facility is there, then at least repeated testing you will know whatever was the reading, now the reading which is coming is showing any change, a real change or not.
Okay. The other question, maybe Dr. Sunil, you can take this. Dr. Nikhil Gokhale is asking, do we need disc photography in addition to OCT imaging every time?
Well, in a general ophthalmology clinic, I think a disc drawing is equally good enough. Disc photography is an expensive proposition if you have a fundus camera and all. Well, maybe unless you are using slit lamp based photography, you can get a picture, but a fundus photograph gives you a better picture. So if you want a disc photograph, you have to use a fundus camera. Coming to whether you need to for every patient, I don't usually use it. Disc drawing, trying to identify the features of the disc and drawing it on the paper can itself help you in follow-up, where you can mention like whether the disc size is more than normal or not, or whether there's a thinning or a nerve fiber layer defect. All that can be achieved with a just basic drawing also. So I usually don't rely on a fundus photograph.
Okay.
Fundus photograph helps in one way, that Sunil, if you are say, seeing patients yourself even after 10 years,
on a long-term basis for fine changes, yes, maybe. But I would comment based on the general ophthalmologist who may not have an access to.
No, not access, then it's definitely not. But then say when you are say after 10 years, probably you will have your record 10 years, even your drawing. But patients
the photograph remains.
Photograph, because patient goes somewhere else or changes his city. Then the patient has something. Because many times patient says that we have seen patient first time, say it's a suspicious, but patient then says, brings out a picture, this photograph, that sir, this was I had gone to some other city and he had taken photograph and 10 years back. So at least then you come to know that okay, this
it's
is
like a reference, like a very good reference.
At this point, I would like to add one more point, which also a question has been there about what is the role of the 3D OCT or the new generation angio OCT along with the other OCTs. Well, the application of angio OCT is not yet specified about the more useful in glaucoma or not. It is all the parameters are under research just now. So we cannot say that angio OCT offers any advantage in glaucoma. But there is another problem which has come up with the angio OCT. The problem is that all the major centers are shifting from the old OCT to the angio OCT, and the database completely changes, and you cannot compare the old records which have been done on the other OCTs, and because of that, progression evaluation becomes a problem. So that is another thing. When fundus photograph, at least it remains for years. OCT, the generation is going to change in next 2-3 years. And when you are going to follow up patients for 10, 20 years, it is not going to work with any of the imaging technologies because those are going to change. Fundus photograph remains standard. Even 20 years later, you can still see the fundus photograph. So I think the question coming back, fundus photograph taking in younger patients. If you have a patient who is 65, 70 years old, it's a different matter. But younger patient, I think it is more important to take the fundus photograph at baseline.
There is one more question again by Dr. Nikhil Gokhale on intertest variability. He's asked, do we know the variation between DISC parameters on OCT? Intertest variability.
So those parameters have been studied by many during when the first OCTs have been introduced, but the amount of data available is not the same for all the OCTs. Like if you today when you go to buy the OCT, we say whether to buy this company, that company, third company, fourth company. There are so many companies making OCTs, but the robust or the reliability of the database and the variation of the database studies are not the same amongst all the OCT machines available. And I cannot definitely give you a very detailed information on which OCT machine has got a smaller database and which OCT machine has a bigger database. But this is, there is data available for the variability or intertest variability for these parameters.
Maybe all three of you all can take a neck. It's keeping on coming again and again in the chat. Nowadays with the coronavirus situation, and we know that some of these patients are present with conjunctivitis and it could be present in the tear film. How do you still do applanation tonometry in patients, and what is your view on that?
So definitely, as of now, we are doing applanation tonometry, and very simple is because the 70% alcohol is known to kill the coronavirus. So you have to clean your applanation head with spirit and wait for 2-3 minutes so that it evaporates. So the best thing what I am following is when I take the tension, at that time I apply the spirit swab on the tip of the tonometer, because then that much time passes and that patient goes and another patient comes, there's enough time for that spirit to have dried. If you don't allow the spirit to dry, that spirit is going to cause a burn of the epithelium of the next patient. So that is what I am doing.
What about your own safety?
We have to use, as in the first lecture on Monday, sir pointed out that we have to use gloves ourselves and mask. And I think even that transparent face shield is a very, very useful thing, I think, because that does not interfere with our working, talking, everything. So with mask and the transparent face shield and using gloves, I think that should be the main criteria for us. And every patient, we have to clean the whole slit lamp and the armrests of your chair with the hypochlorite solution, as sir pointed out in his lecture on Monday.
Okay.
Even the spirit has to dry up, because you won't get the right.
That's what I said. You take the tension and you clean it, and then keep the tonometer on the side. By the time you talk to the patient, write the prescription, it will dry up.
Yeah, means I as a habit, means not today, means at least for last 20 years, but I say we have isopropyl alcohol, 65-67% which comes. So with that we keep in a bottle and swab of that, and just every time after the patient, once we have done it, we clean it. So rightly you said that if you do it immediately or just before the next patient, then you will damage the epithelium, which I have done in past. One patient, that was a doctor. So then with that I learned this lesson. And so what I do after every patient, as long as I'm seeing the patient, I'm only on that slit lamp, not gone away. Always I do the same. But in case next day morning if I come, and I don't know last night someone had done it or not. So again I clean it and then do that. So, but also remember, don't think that non-contact tonometer is safe, because there the puff, the aerosol of the patient's tear film can spread into the environment. And definitely that is, I don't know what Nikhil probably will tell, whether that also is equally infective, because in the conjunctiva, nasal mucosa and the buccal mucosa, where the things start, coronavirus.
Okay. We'll take one more question. This is from Dr. Atul Seth, and another similar one is from Dr. Chintan Dedia. The question is 24-2 program good enough because sometimes 30-2 often gives edge artifacts. So is 24-2 good enough? And Dr. Chintan Dede has asked, is octopus perimetry better than Humphrey?
So as far as the test which you need to do on the patient, the first time probably you may do a 30-2, but 24-2 is usually very good, and only defect in 24-2 is the central field is not as detailed studied. So therefore the new tests are there, which is called a 24-2C, which has got more points in the macular region, or you can do a 10-2 separately and get more data of the central visual field, the central 10 degrees. But 24-2 generally is good enough for most situations. Now coming to whether octopus is better or Humphrey is better, there are definitely very strong points which are in favor of the octopus perimeter. And whether it is better or not, I cannot say, but what I feel is that definitely it is equally good. There are some points where it is can be considered a bit better. Sunil can give more highlights on that because he regularly uses, and I think Rita also has more experience using octopus perimeter.
Yeah. Maybe Nayak sir, can you tell us, because you're one of the pioneers of perimetry, remember? So whether octopus is better than Humphrey, that's the question.
No, means it's basically both. If you use it, if you know how to use it, both are equally good. But there is a caveat that means I give another example. I'll give you, because if you have to keep or recommend one currency, if you are going abroad, which one you will choose? You will choose US dollar, right? Because it's a valid everywhere. So Humphrey perimetry is so common, and even all the publications, this also has been published that about 75% publication on glaucoma is with Humphrey. So the popularity wise, Humphrey is more popular. But if you know how to use it, both definitely both are equally good. Both are equally good.
Okay. We'll take one more question. This is from Dr. Nitin Deshpande. Now he has made a comment here that he finds pattern ERG very useful in tricky cases like high myopia. So what is the panel's opinion on that?
So I have seen some studies in the pattern ERG, and there have been studies to compare it with the visual fields, but a large number of studies and wide-based studies have not been done. So I have not ventured into that area. Dr. Deepak Bhatt can also, we did some patients between ourselves. He did the test because he has the machine. So Deepak can also give some information, but
Dr.
I don't
Deepak
have very extensive knowledge.
Sapnesh, you can unmute him. Dr. Deepak sir around. So Dr. Sunil, any comment from your side?
No, I have no experience with ERG in glaucoma patients.
For any test to become useful and widely acceptable, one thing that it has to be useful, means it should give something different. It should be easily performed and widely available. So the problem with ERG is, even if it is good, because there are hardly few studies only, but then that is done in such a controlled environment that that is not possible to replicate in day-to-day practice. So I will say that as of today, as it stands today, it has got no role except the investigative modality.
Okay, there's one more interesting remark here. Because of today, everybody is sitting idle. A lot of people are probably doing yoga and all that at home. So there is a comment here. I don't know if it's a comment or a question, but can Shirshasana or headstand yoga cause high IOP and problems?
Yes, there is one report which was a study published from Shankar Nethralaya, where it was found that with Sirsasana and Sarvangasana, where you're upside down, more or less complete body, so that raises intraocular pressure. So may not be very significant for majority, and who are normal and just do it for a minute or two, that's all, probably that may be okay. But those who are at risk or glaucoma suspect, then probably it is a serious problem. So I always tell them, in case if you are doing yoga, please don't do this. And so that is what my view is. And basically, I missed that opportunity also of doing this research, because I had already thought of this, made one plan, then complete protocol also was written. Also with the yoga center, I had fixed up. But unfortunately, the doctor who was associated with me didn't realize the importance. And after that, then I also ignored for a year or two. Then suddenly Shankar Netralaya published this report. Then you are not the first one to do this.
Okay. Is Dr. Shaheen Jhaveri is asking, is approach to low tension glaucoma the same as normal tension glaucoma?
Low tension glaucoma and normal tension glaucoma are interchangeable terms.
Okay, so that answers the question. We have one more question here by Dr. Amit Sethi, and he asks, how reliable is ocular response analyzer?
I am using an ocular response analyzer in my day-to-day practice since last 2 to 3 years. And definitely the findings that the ocular response analyzer gives are sometimes not it doesn't fit into the whole picture, because you do a corneal tachymetry and you find out that this patient has got a thick cornea, and you do the ocular response analyzer and it shows you that there is no effect, and that it gives you two readings. It gives you the Goldman applanation equivalent as well as the corneal compensated equivalent, and both are the same. So that means that the thicker cornea is not having any great effect when you do the ocular response test, but the patient does have a corneal thickness of 600. And vice versa also, sometimes it occurs, patient has got a normal corneal thickness and the ocular response analyzer shows that there is a vast difference between the cornea compensated pressure and the Goldman applanation tension. So there are other factors which come into play with the ocular response analyzer, and there are studies which have been done to show that ocular response analyzer is able to pick up patients who are progressing more rapidly than others. In my practice, I think in the period which I have looked at it, I have not really been able to say whether it does or not. But there aren't too many studies showing that, so we cannot say it with that much confidence.
And also, Manish, because you see, I also look at from different angle. Ocular response analyzer is not, say, today's production. It is there for last 20 years. And most of the studies are done at that time. So if this thing was good, then there would have been more follow-up studies and we would have more evidence by now, which is not there. And this machine also would have become more popular. So that also will give you some indication. Probably you should take a hint that whether it is useful or not.
Yes, but having said that, I completely agree. But there are some extreme cases. I have one patient whose glaucoma was completely missed for almost 10 to 15 years because he visited various doctors. Every time his pressure would come and at the 10, 11, he went on progressive. When he came to me, he had a very advanced field defect, even though I found the pressure to be 12 or 13 only. We started him on treatment. With treatment also the pressure was the same. It is only when I got the ocular response analyzer and I made him sit on that I really came to know that his pressure readings, there was a too big a difference. Of course, I have not found too many patients like that. But this chap, the applanation tension is completely wrong always. And we can only take his readings on an ocular response analyzer. I have only one patient, so I cannot make big statements.
On one anecdotal case, you cannot generalize that, oh, this machine.
You cannot. I agree completely.
Because the other way around also, suppose if I want to disprove it, I will also, this means the person who wants to disprove it will bring out certain cases that, okay, now you see, this was absolutely wrong, but the other thing picked up. So,
yes, correct.
Yeah. Okay, good.
Okay, there are two questions on tonometry. Dr. Nupur Goel is asking, would you do a CCT in all glaucoma suspect patients? That is number one. And Dr. Shrikant is asking that, is Perkins comparable to slit lamp based applanation tonometry? So these are two questions you can take together one after the other.
So as far as the CCT is concerned, definitely in all glaucoma suspects, you should do a corneal thickness, because if you have a patient whose pressures are high and the discs are normal and fields are normal, you would like to do it. OHTS, very important risk factor is the corneal thickness. So you have to do it. And vice versa, if you have normal pressures and disc and field changes, then also you have to rule out whether this patient has got normal tension glaucoma or a missed high pressure glaucoma. That also is, you have to do a corneal thickness. So corneal thickness test is definitely a must in all glaucoma suspects. There's no doubt about that. Now coming to the second question is about the slit lamp based applanation and Perkins applanation. Yeah. I have used both, and I have a feeling that on the technique is the same. The principle is exactly the same in both, but the Perkins tonometer, there are more sources of errors because it is not steady. You can change the angles, and because of that, it can get much more variability in pressure readings than you get on a slit lamp based this thing. But however, if you are very skilled, you will get the same reading. So with little better training, it may be the same.
But one difference that if you see the rings, the Myers rings in the Perkins is smaller. So there the chances of the end point error in end point will be more. And only advantage is that yes, you can do it in supine position, sitting position, any position. So in the ward you can carry it, and operation theater you can carry it. So that's the definitely advantage. So it's better to have both if you have got many patients where you get the other things you have to do. In case the ward you have to see many patients, OT you have to do. Then
there's a question here by Dr. Raj Shah, and he's asking what systemic associations and important history points should be looked for in cases of normal tension glaucoma.
So normal tension glaucoma, I think we did not talk of normal tension glaucoma as a topic, but in general with systemic associations, you have to rule out single time kind of burnt out glaucoma situations, such as because of cardiovascular shock, because of steroid use, and other reasons like you have to rule out nocturnal hypotension, you have to rule out sleep apnea, and you have to rule out carotid artery disease. These are all commonly associated with findings similar to a normal tension glaucoma.
Okay. There's one more question about what is the importance of thinning GCC in patients with all normal tests but having high IOP. You know, in such patients, thinning GCC but high IOP and or normal tests, should we treat such patients?
So if the patient has got a high IOP and GCC thinning, means you have got some evidence that this patient is getting some amount of damage. But having said that, you have said that the nerve fiber layer is normal. The perimetry white on white is completely normal. So this is a very, and you have to see the pattern and you have to correlate that. You may find some changes on your clinical examination also. Very small changes also become more important when there is some other change on another test. And if it is so, then probably it might be a good idea to start treatment in this patient, because it is considered to be evidence that earliest change which you are probably going to pick up is going to be on the ganglion cell layer.
Okay, Dr. Sunil, anything you would like to comment on that?
One should not forget the three major machines which we have in the market in India. All three machines don't take into same consideration or same layer they include in the GCC complex. So there is no uniformity in various machines, because that thing you should keep in mind. So I don't think only on the basis of that we should start treatment. But of course, you have got one more tool again to follow, because if everything is normal, this is only showing something abnormal, then again there is no harm in following it up on the same machine and see what is happening. If the retest variability is not much with that machine.
But he has said that a patient has high pressure also. So that is why it becomes 2 points. It's not just 1 point. It is GCC change along with high pressure. So I think then it may
high pressure, suppose if it is more than 25, 26, then even if everything is normal, probably I will start treatment, but not very aggressive treatment. Because otherwise the patient will call then we have to call Preetham to take care of some vascular problem for that patient.
Okay, Dr. Reshma Jhaveri here is asking, in a known case of glaucoma, which secondary IOL should be preferred? And then she also goes on to ask, how much do secondary IOLs like iris claw or glued IOL cause IOP problems? So there are two questions. How much do secondary IOLs cause IOP problems, and which secondary IOL should be preferred in a case of glaucoma?
This is something which IOL to be preferred, because whether it's iris claw or the fixated IOL, because in iris claw lens the chances of some pigment dispersion throughout will be more. So that is one of the things which will contribute. But I don't know. It's difficult to answer which one to prefer.
Okay. Anyone, Manish, Sunil, you have any specific opinions?
See, basically, we don't have any database or study to tell us which one is better. So we have to use our own common sense and decide which one is better. But definitely, as sir said, the iris claw lenses do have incidence of pigment release, and maybe a reason not to avoid them in glaucoma and prefer the ones which are fixated on the sclera instead, with the technique with Dr. Agarwal does.
Okay.
So Pritam, how long?
You know, we had
Pritam,
if Dr. Ragini madam might remember, one of our students, madam, Dr. Payal, had
Yes.
done a thesis on comparing iris claw with glued IOLs. And
Yes.
yeah, and I think we did study the the IOP spikes and glaucoma progression in these patients, but there was not much of a statistical significance, if I remember.
No, there wasn't. But like there are other problems with iris claw. I don't like iris claw because of the CME and also the pigment dispersion, like Manish said. Glued IOLs, again, with the sclera and all, they have their own problems. But best is to have an uncomplicated surgery. And if you have a complication, then you can expect that there will be some enhancement of glaucoma in this patient, and they should be closely followed up, or maybe added, the drops may be added and all, because then you've had a complicated surgery, there might be vitreous loss. So this will all contribute to an increase in IOP more than anyway what the patient had.
Okay.
One more point I would like to make out. Nowadays, for the vitrectomy, all the vitreoretinal surgeons love to use diluted steroid to outline the vitreous strands. And if you are doing iris claw lens, sometimes you need to do a vitrectomy also, though you may not need to do a very extensive vitrectomy. So I would still strongly suggest that in a patient who has glaucoma, try to avoid using that little steroid also, because glaucoma patients are known steroid responders, and how much ever you do, you cannot wash out all the steroid. So some steroid gets left behind, unnecessarily get into trouble. Even if it is for 15 days or a month, you get those pressure spikes with hazy cornea, and you unnecessarily keep on getting all the stress on yourself, and the patient also keeps on worried. So better to avoid that little steroid.
Yeah, and the inflammation will also add to the secondary glaucoma factor.
Yes.
So we retinal surgeons also want to see clear chaka-chak eyes, post-op. But we will keep this in mind from now onwards.
Now will start in 10 minutes. So how long will you continue? Already.
So I think we will just take one last question and we'll conclude. Just this last question: which strategy in visual fields is supposed to be is recommended while screening for job profiles? So I think let's make this as a last question.
So the job profile that you are screening for is very specific. So usually if in patients who require certain amount of vision field in jobs, the companies or the employers themselves give you a requirement. But if you don't have, then if you are doing specifically, you have to do a wide field test, because more important is the peripheral vision. And if you are not looking for specifically glaucoma there, you are looking for vision problems which could have implications in the job that they are going to do. So wider the field you need to study. So probably a 120 point screening would be more useful in such situations.
Yes, a full field, supra threshold. So that is 120 point. Yes.
Okay. Thank you so much. I think, what Dr. Nayak pointed out is right. There is going to be an AIOS webinar on telemedicine and ophthalmology. I'm sure given the scenario today, everyone would like to, attend that also. So I think we will conclude our meeting here. I would like to thank the presenters, the panelists, Dr. ManishS, Dr. Sunil Jain, Dr. Varun Naik, Ragini Madam for joining us, Dr. Rita Damankar, Dr. Preeti Kamdar was here, all the stalwarts, teachers, colleagues, friends. Thank you for joining and giving your valuable inputs for the good question and answer session. And Swapnesh, can you just conclude the session then and just announce what is the next plan?
Yes, sir. So today we crossed 200 quite easily. At one point we had 220 participants. So we need more and more members to join us. Our next CME is going to be on 10th, and the topic is management of diabetic macular edema. The presenter would be Dr. Ashish Vaidya, and chairpersons would be Dr. Atul Ursekar and Dr. Kamdar. So see you all again, and thank you, Pritam sir.
What is the time of the meeting on
6 to 7 p.m.
Okay.
The password and the meeting ID probably will remain the same. I am trying for that. so that it doesn't change. It becomes quite easy for everybody to log in there. Thank you.
So,
Thank
Yeah,
you,
thank you.
everyone.
thank you very
Thank
much.
you.
Preetham, thank you all. Thank you.
Thank you. Thank you, everybody. Thank you so much.
Thank you, Ragini.
Thank you. Thank you. Thank you, Nag sir. Thank you, Sunil. Thank you, Swapnesh. Very well done. Thank you, Preetham. Thank you, everybody, for the time.
Thank you.